Good afternoon. It is now 50 minutes after the hour, and we'll reconvene the ACIP meeting to begin oral public comment. I'd like to welcome and thank our public comment speakers for addressing the committee today. All the speakers today submitted a request in advance of the meeting, and I realized there wasn't very much time, and the final list of public commenters was determined via a lottery. For our speakers today, we have a limited public comment period. And again, in order to make it through all of the listed speakers, it's extremely important each speaker limits his, her, or their remarks to 3 minutes. We will be displaying a timer on the screen so you know how much time you have left. As a gentle reminder, our committee appreciates diverse viewpoints that are respectful in nature and issue focused, rather than comments directed at individuals. Thank you again to our speakers, and we look forward to your comments. Our first public comment speaker for today is Dorit Rice.
Can you hear me?
We can, thank you.
Wonderful. Thank you for the opportunity to comment. My name is Dorit Rice, and I'm a professor of law at the University of California, Hastings College of the Law. I have 4 points to make. I hope I can get through them. First, I want to reiterate how useful and important it is for you to have these open, transparent discussions. As Dr. Cohen pointed out, you've met for over 24 days. And to thank the committee members, the guests, and professional staff for preparing these labor-intensive presentations on vaccine safety. Thanks to you, we, the online advocates, have a good answer when anti-vaccine activists try to claim the safety data is not looked at, because you provide the data and committee members ask penetrating questions that get more information about it. I know it's a lot of work. I want you to know that it really matters. Second, I'm not a scientist, but I am a parent. My kids, like millions of kids in the United States, are going back to schools. Our schools are taking precautions, but with Omicron, that may not be enough, and not all schools are. I know you will focus on the science, but I want to ask you to consider, among the benefits, the effect of children's lives and their parents of how vulnerable they are to infections in school. Even if vaccinated children don't get severely ill from Omicron, their life has been already disrupted. At least most of them don't get ill, I hope. And if a booster can reduce the risk of disruption in a meaningful way, that matters. Third, Dr. Cohen pointed out that you're moving to have more recommendations done by CDC without ACIP input, which, given the extensive work ACIP done, makes sense. Yesterday, the CDC published a recommendation about 2 of the 3 things the FDA authorized, and some people asked whether the CDC has already made up its mind before hearing from the committee. It's great that the CDC is mindful of the limited number of the experts in the committee and not using that time for smaller items, but I hope you consider the messaging there and make it clear when and why things go to the committee and when and why they do not. And going forward, it might be a good idea to add a line on why CDC decided that this does not need ACIP input, just to avoid appearances of not listening. Transparency about the process is really important right now to maintain trust. Finally, on process, there's a real problem, and this is directed more at the CDC's committee staff than the committee members. The agenda for this meeting only went up around 8 a.m. my time today, 11 a.m. Eastern time. The public commenting announcement came later, and this is the second time it's been day off. I realize it's an emergency meeting, but the Federal Advisory Committee Act requires notice in advance for transparency, and that really matters. Anything you can do to have the agenda up 1 or 2 days in advance and have the commenting up will make a real difference. I know you're under a lot of pressure, but day off really is an issue. Thank you very much.
Thank you for your comment. Next, we have Mr. Kermit Kubitz.
Hello, my name is Kermit Kubitz, and I have no conflicts. I have, as an early vaccinated person at the San Francisco Veterans Administration, been a substitute in-class IT person while teachers taught remotely, and I turned on projectors and counted students at a local high school. And this experience informs my comment. I support booster doses for adolescents for 3 reasons. The first is the startling increase in COVID cases among children. The second reason is the benefits of vaccination in reducing infection and spread among school-aged children to others, including teachers and the unvaccinated. The third reason is the protection boosters give against existing and possible new variants, including Delta, Omicron, and future variants. First, there is a rapid increase in COVID-19. New COVID-19 cases in children in the U.S. increased nearly 64% over the prior week, according to data published by the American Academy of Pediatrics. For the week ending December 30th, there were more than 325,000 new cases among children, the highest count ever reported in children over the case of the pandemic. While it appears that severe illness due to COVID-19 is uncommon among children, there are still threats to immunocompromised patients and those with whom they interact. A second reason for vaccination and boosters for children and adolescents is to keep children in school, participate in sports and other group activities. Schools in Marin County have had to close gyms to spectators, and schools in Chicago have had to go back to remote learning and undesirable retrogression. The final reason for boosters is to protect against both existing variants such as Delta and Omicron and new variants such as the multi-mutation variant recently identified in France, IHU, that causes COVID-19, also known as B1640.2. While its severity and infectiousness are not known, boosters will clearly produce more protection as we go forward. I thank you for the opportunity to comment as I have on previous December 1st and December 12th and June 24th ACIP meetings, and I thank you for your work and best wishes for the new year as we get this pandemic under control through vaccination. Thank you very much.
Thank you for your comment. Next, we will move on to Joan Allisteen.
I'm Joan Allisteen, a registered nurse with a doctorate in public health and faculty in the School Nurse Credential Program at the California State University in Sacramento. Thank you for the opportunity to comment. I have 3 points to make. One, we all so value the work of this committee to truly rely on the science and evidence in making recommendations for vaccines that are clearly safe and effective and completely support the committee recommendations. Unfortunately, we have not had clear, consistent messaging from the CDC, leaving risk decisions to individuals because of the confusion caused. That includes not following expected protocols and announcing changes before the appropriate committees meet and their recommendations. Second, I again raise the issue of the need to actively involve and model a relationship with school nurses who care for our country's pediatric public health population to have a successful vaccine campaign. The CDC has noted school nurses are trusted vaccine ambassadors. In studies of HPV vaccine, for example, a controversial vaccine, intervention schools have higher rates of vaccination than non-intervention schools. We know that engaging parents in schools increases vaccine uptake. As in all areas of healthcare, we are losing school nursing staff at a critical juncture. The CDC should include in all school-related recommendations that school nurses be actively included in assessment planning, policy, program development, implementation, and evaluation of both vaccine programs and mitigation efforts. Funding should be targeted to school nurse positions. Rather than eliminating or ignoring school nurse positions in districts, the CDC should take the lead in recognizing the importance of including school nurses in all recommendations and enjoining state, county, and city health departments to partner with school nurses at the district and school levels to carry out this critical task of getting our pediatric public health population vaccinated. I ask that the CDC work directly with the National Association of School Nurses to help improve vaccine outcomes, especially in vulnerable communities with lower rates of vaccination. On CDC process number 3, I so appreciate the work of this committee made even more difficult by the demands of a pandemic. Having the agenda posted the day of the meeting rather than in advance for both transparency and meaningful public participation would be helpful to change. In submitting a request for public comments, it feels like the CDC Oscars. Those of us who put in the request must make their acceptance speech in advance, only to find out just before the meeting whether they've won. If public comments are at the beginning of the meeting, notice may arrive in the middle of the night for those of us on the West Coast. Thank you very much for this opportunity to speak, and I wish you a healthy, happy, pandemic-free year.
Thank you for your comment. Next is Dr. Julie Boom.
Thank you so much. On behalf of Texas Children's Hospital, I would like to thank the CDC staff and ACIP members who have so diligently analyzed COVID-19 disease burden, vaccine safety, and efficacy data, and then so adeptly provided risk-benefit assessments based on this information. Using your in-depth analyses, my colleagues and I have been able to assure families about the safety and efficacy of COVID-19 vaccines for all persons 5 years and older. As a general pediatrician with 26 years of experience and director of the Immunization Project at Texas Children's Hospital, I know that vaccines are the best way to protect all persons from COVID-19 and are our best hope for ending the pandemic. As you continue your discussions today, I urge you not to minimize the disease burden and risk of COVID-19 in children and adolescents. With the arrival of the Omicron variant, children's hospitals across the nation are reporting dramatic increases in COVID-19 hospitalization. To date, almost 7 million children have been diagnosed with COVID-19, resulting in over 80,000 hospitalizations and more than 1,000 deaths. Early data suggests that the Omicron variant is more contagious and spreading quickly through our pediatric and adolescent populations. Additionally, Omicron has resulted in breakthrough cases following full vaccination at record levels. Fortunately, early data suggests that booster doses may mitigate this phenomenon. As COVID-19 vaccine was initially approved for children 12 years and older on May 12, 2021, many adolescents could already be experiencing waning immunity and could benefit from a booster dose. As we near the 2-year mark of the COVID-19 pandemic, we must do everything in our power to minimize any further detrimental effects to the mental health, physical well-being, and education of U.S. children. Because of Omicron surges, many educators are again facing the difficult decisions regarding the safety of in-person learning for both teachers and students. For these reasons, a booster recommendation for children 12 years and older cannot come soon enough. Please give these factors your strongest consideration as you weigh the benefits and risk of COVID-19 booster doses for children 12 years and older. Thank you so much.
Thank you for your comment. Next, we have Dr. Richard Paul Junghans.
I'm Richard Junghans. I'm a medical oncologist and hematologist and immunologist with 30 years experience in the field of immunology. Title of this is Saving Jobs, Lives, and Vaccines, Exempt Prior Infectees from Mandatory Vaccination. I am pro-vaccine. Whereas vaccinating everyone makes sense, there is a nuance to the situation with vaccine-averse people that can be exploited to everyone's benefit. Let's say 50% are vaccinated and we want to get to 100%. We provide incentives, we threaten their jobs, and in general try to shame people as healthcare troglodytes to get their vaccinations done. I want to appeal to the science, not politics, not morality, not expediency. That is, let us find the population that is truly at risk and reduce the focus to this subset. The population at risk are those who have neither been vaccinated nor infected. So far, public health agencies have chosen to ignore prior infectees and treated them the same as the susceptible population. This is a gross error and a missed opportunity. In general, the consensus view is that natural immunity that arises from exposure to all viral proteins is superior to vaccine immunity with exposure to one viral protein. Accordingly, I propose that all prior infectees be designated the same as vaccinated, as is currently being done in Israel with issued green cards. Unfortunately, the CDC has not followed the data to make this recommendation, which only favors profits of the vaccine manufacturers, subjects rare patients to medical risks, and does not increase the safety to those already naturally immunized by infection. And it also decreases available doses to countries who are desperately underserved. In April 2021, CDC estimated 40% of the adult population was previously infected, with a much higher likely prevalence among frontline workers whom we disproportionately target with mandatory vaccination. The impact: if we exempt prior infectees, this legitimately reduces the at-risk group from 50% down to 25 or 20% or lower, much more manageable numbers. Any prior positive PCR antigen or antibody test exempts them. Not everyone had proof of prior infection, but offering antibody tests to non-vaccinated employees will inform, and if positive, they are exempted. This has the further benefit of engaging the employee in his or her own health choices and more likely to be agreeable to vaccination when offered after a negative test. We follow the science and avoid aggressive, even classist mandates would selectively impact the poor economic classes with these threats, then this proposal to treat prior infectees as vaccinated is an easy choice, respectful, without caprice or arbitrariness, and it follows the science, not politics. In this case, I predict this proposal will increase vaccine participation while also decreasing social strains. I will post online further supportive documentation. Thank you.
Thank you for your comment. And I want to thank all of our public comment speakers. We really truly value your public input in these meetings. And next, we will move on to the session that will begin with, I believe, Dr. Evelyn Twentyman will provide the committee an update on clinical considerations, including and incorporating some of the recent updates from earlier this week. Dr. Twentyman.
Thank you so much. Could we bring up the slides? My name is Evelyn Twentyman, and I currently serve as Chief Medical Officer for CDC's COVID-19 Response Vaccine Task Force. I will be providing a high-level overview of some of our recent updates to our interim clinical considerations for use of COVID-19 vaccines, as well as a preview of updates to these interim clinical considerations planned to follow today's ACIP meeting. Next slide, please. Over the next few minutes, we'll draw your attention to some of the most recent updates to these interim clinical considerations and our anticipated next steps. We'll briefly review highlights from each of the last 3 updates made throughout the month of December, and then turn our attention to updates we anticipate coming later this week, including any outcomes of our meeting today. As you can see here, we'll touch on our updated guidance for booster doses in adolescents ages 16 to 17 years, updated guidance on use of the Janssen vaccine, including ACIP and CDC's preferential recommendation for mRNA vaccines for both primary series and booster doses, and our description of the newest formulation of Pfizer-BioNTech's COVID-19 vaccine, also known as the Gray Top. And then we'll turn to updates we expect later this week. You'll see here that, of course, we anticipate including guidance to reflect outcomes of today's meeting, including any recommendations ACIP decides to offer. And we'll also briefly describe 2 additional updates to make based upon FDA's Regulatory Actions Monday, with recommendations by CDC through decision memos announced yesterday, including recommending a 3rd Pfizer-BioNTech primary series dose for children ages 5 to 11 years with moderate to severe immunocompromise, and a decrease in booster interval after Pfizer-BioNTech primary series from 6 months to 5 months among those who are booster eligible. Before beginning, I want to caveat that this is meant to provide you with a nice high-level picture of what most significant changes have occurred most recently, and those that will come next. We did make a number of other small updates over the course of December to ensure alignment with updated links or language or guidance for specific providers or professionals, and have made many other evidence-based updates to our guidance since COVID-19 vaccination began over 1 year ago. We won't be able to discuss every one of these here, but before moving on, I wanted to note that you can find a list of all historical updates to our interim clinical considerations by either going to the interim clinical considerations page and scrolling to the bottom, or you can simply click this link here at the bottom of this slide and go immediately to this entire list. Next slide, please. First, we'll describe our latest updates. Next slide, please. On December 10th, we updated our interim clinical considerations to include guidance that adolescents ages 16 to 17 years may receive a booster dose of Pfizer-BioNTech COVID-19 vaccine at least 6 months after completion of their primary series. As you might recall, as we discussed briefly at our most recent ACIP meeting, this decision was based on data previously reviewed by ACIP, though not specifically discussed and voted upon then, as it was not relevant in the context of emergency use authorization, or EUA, for Pfizer-BioNTech at that time. Given, however, the reassuring safety data ACIP had recently reviewed, the relative vaccine efficacy for booster vaccination of more than 95% among adolescents who had received a recent booster compared with those who had not, and the need for it, as evidenced by the emergence of the Omicron variant and the number of adolescents who would be immediately eligible, it was recommended, following FDA's amendment of the Pfizer-BioNTech EUA, that people ages 16 to 17 years may receive a booster dose based on their individual benefits and risks. Next slide, please. On December 16th, ACIP reviewed updated benefit risk assessments pertaining to the Janssen COVID-19 vaccine in the context of identification of additional cases of thrombosis with thrombocytopenia syndrome, including deaths, and in the context of increased supply of alternative mRNA vaccines in the US. ACIP voted that mRNA COVID-19 vaccines are preferred over the Janssen vaccine for the prevention of COVID-19 among those who are eligible for either mRNA or Janssen vaccine. Next slide, please. Then, moving forward to December 23rd, just in time for the holidays, ordering opened for the newest authorized formulation of the Pfizer-BioNTech COVID-19 vaccine, nicknamed Gray Top. We updated our interim clinical considerations this same day. To briefly highlight differences between this Gray Top formulation, for which ages 12 years and older are eligible, from the previously released Purple Top formulation for the same age group, the Gray Top formulation does not need dilution, can be refrigerated longer, can stay at room temperature longer, and can remain in use after first puncture twice as long as its Purple Top predecessor. Next slide, please. And now turning to a new month and a new year. Next slide, please. On Monday, FDA extended authorization of a third primary dose for certain immunocompromised children ages 5 to 11 years, and CDC followed this with the same recommendation in a decision memo announced yesterday. There was some sense of urgency here in our eagerness to protect children with moderate to severe immunocompromise. We have seen that vaccine efficacy is lower in patients with immunocompromise. CDC does already recommend a third primary series dose in those aged 12 and older with moderate to severe immunocompromise. We know that approximately 1.4 million children in the US ages 5 through 17 have an immunocompromising condition consistent with our definition of moderate to severe immunocompromise, which we'll review momentarily. Only those immunocompromised children ages 12 to 17 in this group, however, were previously covered by this recommendation to receive a third primary series dose. In addition to this sense of urgency, we have a quite encouraging sense of safety at the same time, thanks to the reassuring findings of vaccine safety surveillance for children ages 5 to 11 years. You've seen some of these data presented already today and published in this MMWR report on December 31st. For now, and in the interest of time, I'll underscore again that during administration of more than 8 million doses of Pfizer-BioNTech to this group, serious side effects were rarely reported. Next slide, please. I promised we'd review our definition of moderate to severe immunocompromise, and here it is. You'll see our same 6 clinical categories here, as our working definition has not changed, and we can now say that children ages 5 to 11 with one of these conditions can now benefit from a third dose in their primary vaccine series. Next slide, please. We have also gone forward with a decision memo recommending a decreased booster interval of 5 months for those booster eligible following completion of a Pfizer-BioNTech primary series. Our sense of urgency here came from the rapid expansion of the Omicron variant, with which I'm sure you're unfortunately very familiar, and with observations that people who have completed both primary series and booster may be better protected against symptomatic infection with the Omicron variant than those without booster. In addition to that, we can learn from the experience of our Israeli colleagues who have used a 5-month booster interval in their administration of Pfizer-BioNTech vaccine and observed effectiveness against severe illness and death when compared to those without booster. We could detect need for this in the US, given that as of yesterday, just 38% of fully vaccinated adults have received a booster. Many adolescents are potentially eligible as well. As of Monday, over half of US adolescents in the currently booster-eligible age group are vaccinated, but only 6% of these have received a booster. Lastly, turning back to the experience of Israel again for a moment of some safety-related observations of the 5-month booster interval. Those rare occurrences of myocarditis in people ages 16 years or older after their second dose were even more rare following a booster dose. Next slide, please. I'll wrap up with an explanation in visual form here, demonstrating vaccine booster dose by primary series. At least 5 months after completing a Pfizer-BioNTech primary series, at least 6 months after completing a Moderna primary series, and at least 2 months after completing a Janssen primary series, people who are booster eligible can receive any of the vaccine products for which they are eligible. I'll also offer a comment on eligibility here, as the age group eligible for Pfizer-BioNTech booster may change based upon outcomes of today's meeting. You will see updates to our interim clinical considerations include any outcomes of today's meeting, in addition to these updates I've just described. Next slide, please. With that, I'd like to pause to thank the many hardworking people who have contributed to this presentation, to our rigorous understanding of vaccine safety, and to our frequently updated evidence-based interim clinical considerations. And next slide, please. I'd like to thank you for your time, and I'm happy to take any questions. Thank you.
Thank you, Dr. Twentyman. This presentation is now open for questions. Ms. Bata.
Thank you so much, Dr. Twentyman. I don't really have a question as much as I have a comment, and it's just, again, from that perspective of practicality and feasibility. We've got 3 COVID vaccines with 3 different intervals, and this complexity is really confounding to play out practically. And I know that as a ACIP decision maker, that we can't do much about that, but I'm hoping that you will have some good clinical consideration guidance if some of these, if something like Moderna is given at 5 months instead of 6 months, because I know that that's going to be happening. Thank you.
Thank you, Dr. Bata. We do endeavor to make our clinical guidance as easy to follow and as intuitive as possible for the American public and the healthcare providers that serve them. And we will continue to do that in any context we're working in, such as these 3 different booster intervals that we have as of today. And we will continue to frequently update our recommendations as soon as we can, given any updates to policy or authorization in the future. Thank you.
Thank you. Dr. Long.
Yes, it's a question a little bit for the CDC leaders there, and for you, Dr. Lee, about what comes to this committee and what does not. For instance, if we don't see data and we just hear about these things, these interim recommendations that are changing, we don't have an opportunity to question the data, to expose what is available and what the big gaps are. For example, we saw some data about immunocompromised in response to vaccine very early on, but everything else has sort of been tagged on. And obviously, I want to protect children 5 to 11 who didn't respond to the vaccine, first 2 doses, with another dose. But I think this is exactly the age group and the condition in which the risk of myopericarditis is significant if they responded to dose 1 and 2 to get another dose in the presence of high antibody to spike protein to get another message for spike protein. And these are children whose hearts may be challenged by chemotherapy and steroids and drugs and other things. So my question is, has the work group seen the data along the way and agrees with the change in, the changes? For instance, let's just focus on the inclusion of a third dose for 5 to 11. Because I would think, since many transplant centers and many others are doing semi-quantitative or quantitative antibody tests, and because the CDC has said we don't count on those because we don't have a marker of protection, I think we're losing the ability to know that if someone has a high antibody to spike protein, we know they've responded to the vaccine. And I think those are the ones who are particularly at risk for mild pericarditis, and would say this is not the time to give them a dose, because the numbers that I have seen, they're either nothing, and of course they need it, or they're extremely high after the second dose, and I wouldn't want to give that child a third dose. So a little bit question about process, and a little bit about, has CDC reconsidered as antibody tests are, probably reproducible now, considering the use of those in immunocompromised, to make the decision for the third dose at 3 months. Thank you. Sorry.
Thank you, Dr. Long. I want to see if our colleagues in the room at CDC would like to comment, and I'm happy to provide my opinion.
Dr. Long, thank you. This is Melinda Wharton. Regarding what questions will be coming to the committee and which ones aren't, for the incremental extensions of recommendations, we do not, these have not all come to the committee, and we probably will be having fewer of them come forward in the future because of the limited amount of additional information available to address those. There's a number of substantial issues that we would really like to be able to engage the committee to discuss, and I think we're going to try to increasingly focus in that direction going forward. Dr. Lee, do you have additional comments?
Sure, I'm just going to share my opinion, and I appreciate the question, Dr. Long, because it's something that I think we as a committee have been struggling with. I'm going to give a long answer. I hope that's okay. In routine scenarios, ACIP, of course, deliberates on new vaccines, new indications or contraindications, new schedules, et cetera. And our goal is to ensure that we are providing a timely response following FDA authorization or approval of a new vaccine product or a new indication. Those meetings are typically 3 times a year, and as you know, well scheduled in advance. In the pandemic scenario, we are under a public health emergency. I mean, timeliness is essential for all of us, and we know this based on our frontline work as clinicians or as public health practitioners. And we recognize that decision-making is typically in the context of uncertainty. So, in my view, ACIP should continue to serve the purposes it was set out to do, which is number one, to provide advice and guidance to the director of the CDC regarding use of vaccines and related agents to effectively control vaccine preventable diseases, in this instance, COVID. And number two, to ensure that the public has knowledge of and an opportunity to provide public comment on meeting topics in order to ensure transparency in our decision-making and enhance public trust. But I also have to just comment that the urgent demands of the pandemic response and the way that our committee is structured has created challenges. And so we have to acknowledge those challenges and make sure that we are continuing to fulfill our function and role, but allow our public health agencies the flexibility to respond in a timely manner. And I anticipate that we are going to be hearing from our FDA colleagues on a fairly routine basis, as there's a series of decisions that we anticipate will be coming quickly, over the next few weeks, months, and beyond a few months. So in order for us to be responsive as an agency, I hope that what we can do is focus on issues that impact overall population benefit risk balance, and where public discussion is critical for transparency and trust. So, I anticipate we will continue to evolve, but I do want to recognize that the demands on ACIP have been far above and beyond a typical federal committee structure, and that I think we're going to have to learn together about making sure that we are serving our purpose and our function while also being responsive to the pandemic. So we recognize that, again, every emergency meeting, we ask our ACIP members and our liaisons and our CDC staff to attend adds additional burden. And we are trying to find a way, as Dr. Cohen mentioned early on, to continue to make this feasible, sustainable, and impactful in terms of the discussions that happen. But this is, just my opinion. And I do think we need to enhance the predictability of these meetings, as was mentioned multiple times over the course of today. And we need to be able to support a sustained response, because I don't think things are going to change. I was hoping we would be done after a year. I was hoping we'd be done after 2 years, and it's becoming clear to me we are heading into year 3, and we are not done by any means. So, welcome additional comments or feedback on that approach. But again, these are just my opinions. I'm going to move on to Dr. Sanchez.
Thank you, Grace. I don't think we will ever be done, but that's personal. We'll just have to live with this and control it by vaccination and other means. But my question, certainly the myocarditis has been the concern throughout. And as I was looking at this immunocompromised children and the recommendation for an additional primary series, has there been much myocarditis, and thinking about the pathogenesis and of course booster dosing then for the 12 to 15-year-old as well, has there been much myocarditis that has been reported among the 1.4 million children who had an immunocompromised suppressive condition? It seems to be that those children really have not had much, and maybe it's because of the lack of antibody production, or just trying to sort through some of the pathogenesis and some of what Dr. Long was saying. It seems to me that the myocarditis has not really been an issue with those individuals, and whether it may be after a third dose.
Dr. Sanchez, this is... Oh.
Great, thank you. Go ahead.
This is Dr. Oliver. I just want to say, so agree with you that, if we think through so many of the, and I'll see if Dr. Shimabukuro wants to specifically comment there, I think we don't have kind of specific surveillance for myocarditis, solely in immunocompromised populations, but I think it does, from a pathophysiologic, make sense that the children who are immunosuppressed and not having kind of these robust immune responses may not be the highest risk population for myocarditis after these doses. So I think the consensus kind of on the work group was exactly what you mentioned. Dr. Shimabukuro, any kind of comments from y'all's surveillance?
I'll just confirm that we don't specifically conduct safety surveillance in immunocompromised populations. I will say that we review all case reports of myocarditis that come into VAERS in an attempt to follow up and get medical records or contact the physician as part of our adjudication to see if they meet case definition. And I'm not aware of any unusual or unexpected findings in these case reports with respect to immunocompromising conditions. So I don't think that we have any evidence to suggest a safety issue, above and beyond what we're observing in our routine surveillance for the specific immunocompromised patient population.
Thank you. We'll move on to Dr. Paling.
Yeah, thank you, Dr. Twentyman and the entire committee for this robust discussion. I wanted to
make one comment, and that is that I've received many questions about providing additional coverage for immunocompromised children that were younger than 12. So this will be welcome news for many. And then I wanted to ask a point of clarification. So the children who are immunocompromised down to 5 can now receive a third primary dose. Would they also then be eligible 5 months later to get a booster dose? Thank you.
Thanks so much for your question. Children ages 5 to 11 are now eligible for a third dose in the primary series who have moderate to severe immunocompromise. This age group is not yet booster eligible. So thank you for asking this question because it allows us to draw a distinction between primary series and booster. And what we're talking about in these 5 to 11-year-old kiddos with immunocompromise is a third dose in the primary series. Does that help? Thank you.
Yes, thank
you. Thank you. Dr. Daly. For some reason, I can't hear you, Dr. Daly.
Okay, I'm having mic problems. Can you hear me now?
We can, thank you.
Okay, my apologies. I'm on a loaner computer in clinic, and so it's been difficult to connect. So I have a couple comments. One is Dr. Long asked whether the work group had reviewed new data about antibody titers in immunocompromised 5 to 11-year-olds, and no, in the last few weeks we have not. I mean, I think I want to emphasize a couple points and then maybe ask Dr. Cotton to weigh in. But you know, Dr. Long, part of the process that got us to this point was the FDA's review of their interpretation of risks and benefits of vaccination of immunocompromised, and then their assessment that the benefits strongly outweighed the risks. But then to the second point about kind of what should come before the committee, you know, I do know that there was a lot of discussion from leadership at the CDC about what should the committee discuss today, and the decision was made to focus on the booster doses in the 12 to 15-year-olds. But that doesn't mean we can't sort of think about, talk about, and comment on the other issues, you know, in front of us. And then I think I would ask Dr. Cotton, if she's on, if she could comment about her perceptions about additional doses in 5 to 11-year-olds who are immunocompromised. Over.
Thanks. It's Camille Cotton. I'd be happy to comment, although I'm not a pediatric provider, but what we are seeing in immunocompromised patients is a marked reduction in vaccine efficacy and protection from disease. And so I do think that with Omicron, things are really different than before as far as vaccine efficacy. And I really think that now is the time to think about additional doses of vaccine actually for all immunocompromised patients, perhaps starting as early as maybe 4 months after their last dose, after they've finished their primary series. And I really think this is an important opportunity to think about that. One thing that hasn't really come out of the discussions today is the overall risk of developing myocarditis and other life-threatening conditions, not just from vaccine, but from disease itself. I am seeing devastating amounts of disease in immunocompromised patients. I'm seeing, I know that in general, Omicron is touted as being less severe. However, for poorly vaccine-protected immunocompromised patients, I'm seeing life-threatening disease. I have numerous patients who are on life support in the intensive care unit. We've had other patients die. This is a horrible state of affairs for immunocompromised patients. So although we've been deliberating a lot about vaccine side effects, I would really like to also focus on disease itself, which is astronomical proportions. And although I know that the immunocompromised patients I care for have been very, very diligent in avoiding getting infected, the highly infectious nature of Omicron is such that patients who've been incredibly careful for the better part of the past 2 years are now getting infected. with awful outcomes. So I would both advocate for better examination of how devastating disease can be, especially at the rates we're seeing, but also I would really like to advocate for additional doses of vaccine for all immunocompromised patients. Thank you.
Thank you, Dr. Daly and Dr. Cotton. Dr. Sanchez?
Thank you. I just had a comment. So, or a question or clarification, I guess. So the immunocompromised child 5 to 11 who has received a 10 microgram dose, I assume that as with similar recommendations before, once they reach, if they've already now 12 years and older, they will be getting a booster with a higher dose?
I think perhaps that is one of the discussion points for today. I don't know if Dr. Oliver wants to address that now or if we want to move on to Dr. Oliver's presentation next.
Let me see.
Just to clarify,
Can we just clarify that children who change ages, at least once a year, are dosed according to the age they currently are. So I think I heard the question to be if they were voted into eligibility at the age of 12 for booster today at this ACIP meeting, if they previously had a dose of 10 micrograms, would that change their dose of booster between the ages of 12 and 15? And I'll just go back to our guiding principle that children, as all individuals, are dosed based on their current age at the time they go for vaccination, according to our clinical guidance. Does that help? Thank you.
Yeah, no, that's perfect. I just wanted clarification. Thank you.
Any additional questions? Any questions from our liaison members? Recognizing implementation is challenging. Okay. I see no further hands raised, so we will move on to Dr. Sarah Oliver, who will walk us through the updates to the evidence to recommendation framework for boosters for 12 to 15-year-old patients.
Dr. Lee, give us just a second. We're getting the slides back up.
Thank you.
All right. Thanks so much and good afternoon. Next slide. So just as a reminder, this is the EtR framework that we've used for our previous booster dose recommendations. Next slide. Then this slide shows a timeline of the recommendations for COVID-19 booster doses over the last several months. We first reviewed data and voted on booster doses for the Pfizer vaccine in September. Then in October, this expanded to the Moderna and Janssen vaccines, including recommendations for heterologous boosting. In November, the booster recommendations were broadened to include all persons 18 years of age and over. In December, this was extended down to 16 years of age. Then in January to date, we've shortened the interval between the primary series and booster dose to 5 months for the Pfizer vaccine. And next slide. Then today we're discussing booster doses for those 12 to 15 years of age. Next slide. So then as a reminder, this is the visual for the current recommendation for booster doses. Booster doses are recommended as a should receive the booster for all 18 years of age and over. The interval between the primary series and the booster depends on what primary series was received. Then those 16 to 17 may receive a booster at 5 months after the receipt of their Pfizer primary series. Next slide. So this is the policy question we'll be discussing today. Should individuals 12 to 15 years of age receive a Pfizer-BioNTech COVID-19 vaccine booster dose at least 5 months after completion of the primary series, based on the balance of benefits and risks? Next slide. So moving to the public health problem, next slide. As of January 3rd, there have been over 56 million cases of COVID reported in the US. Cases have rapidly increased starting in early December due to the increasing prevalence of the Omicron variant. As of January 3rd, the 7-day average had reached an all-time high of nearly 500,000 cases. Next slide. Then this figure shows the nowcast projections, showing the increase in the prevalence of the Omicron variant that's shown in purple. As of the most recent week available, ending on January 1st, Omicron made up over 95% of cases. It's important to note that the most recent estimates are drawn from a modeled forecast, the nowcast, that attempts to account for delays associated with testing and genotyping, as well as various biases in surveillance. Next slide. This figure shows COVID-19 incidence rates over time by age group, with the 12 to 15-year-olds represented in yellow. Since this summer, adolescents have had a somewhat higher incidence rate than adults and are currently experiencing the incidence increase seen across age groups due to the Omicron variant. Next slide. Then this figure shows COVID-associated hospitalization rates by age group, with 12 to 15-year-olds once again represented in yellow. Throughout the pandemic, the pediatric and adolescent age groups have had lower hospitalization rates than adults. To highlight the recent trends in the 12 to 15-year-olds, we'll zoom in the data on the red box, which looks at the pediatric-only age groups, focusing on trends in the most recent months. Next slide. So then this figure shows COVID-associated hospitalization rates among the pediatric age groups from July through December, with 12 to 15-year-olds once again depicted in yellow. Because there are fewer events in these age groups, you can see that there's some variability and the rates bounce around a little from week to week, but we still can see the overall trends. We see a slight increase in hospitalization rates from the summer, but overall rates have remained relatively steady. It's important to note that these dates go through December 10th, and so may not show the significance of the Omicron variant yet. Next slide. Then this figure shows COVID-19 incidence rates among 12 to 17-year-olds by vaccination status. As you can see, the majority of COVID cases continue to occur among the unvaccinated, with unvaccinated 12 to 17-year-olds having about 7 times higher risk of testing positive for SARS-CoV-2 compared to vaccinated 12 to 17-year-olds. Next slide. This figure is similar to the one on the previous slide, but now we're looking at COVID hospitalization rates among 12 to 17-year-olds by vaccination status. Unvaccinated 12 to 17-year-olds have around 11 times higher risk of hospitalization than vaccinated 12 to 17-year-olds. Next slide. We have a few studies that have given us early estimates of vaccine effectiveness in this adolescent age group. The first one we'll discuss is a prospective cohort study, which followed 12 to 17-year-olds in Arizona from July through December to estimate vaccine effectiveness against SARS-CoV-2 infection. Next slide. When comparing 12 to 17-year-olds vaccinated with the Pfizer vaccine with unvaccinated 12 to 17-year-olds, this study estimated an adjusted vaccine efficacy against infection of 92%. Next slide. The next study we'll discuss comes from the Increasing Community Access to Testing, or ICAT, partnership. This is a test-negative study design which covers a period from July through October and evaluated vaccine effectiveness to prevent symptomatic infection. Next slide. In this figure, we see a comparison of the Pfizer-BioNTech VE against symptomatic infection between adolescents 12 to 15 and 16 to 19 years, and then adults 20 years of age and over, by days since second dose, with the 12 to 15-year-old shown in red. VE is the highest among ages 12 to 15, then followed by 16 to 19-year-olds, then adults 20 years and over. And you can see the VE wanes among all age group with increasing time since vaccination. It's important to note this analysis reflects a period with the predominance of the Delta variant. Next slide. In this final study, we look at effectiveness of the Pfizer vaccine against COVID hospitalization among persons 12 to 18 years of age. This was a test-negative study design of children and adolescents hospitalized at 19 pediatric hospitals from 16 states from June through September. Next slide. This study estimated that vaccine effectiveness against COVID hospitalization in persons 12 to 15 was 91%. And again, this study reflects the Delta dominant period. Next slide. So I want to highlight data from an analysis that will be published later this week. The authors allowed us to share the information preprint through a test-negative case control design that included MIS-C cases and hospital controls 12 to 18 years of age from July through December. And they showed that the vaccine effectiveness of 2 doses of the Pfizer vaccine in this population against MIS-C was 91%. 95% of hospitalized children with MIS-C were unvaccinated. The vaccine also attenuated MIS-C severity. None of the 5 vaccinated children who subsequently presented with MIS-C after SARS-CoV-2 infection required respiratory or cardiovascular support. Next slide. So in summary for the public health problem, the US is experiencing a substantial increase in cases over the last month. The Omicron variant represents around 95% of recent US cases. COVID cases and hospitalizations are 7 to 11 times higher in unvaccinated adolescents compared to vaccinated adolescents. And vaccine effectiveness in adolescents 12 to 15 years of age remains high, but may have some waning over time. However, it's important to note that the current VE estimates are primarily in the setting of the Delta variant and may not represent the current situation with the Omicron variant. Next slide. So now as we think through the benefits and harms, next slide. As a reminder, when discussing recommendations for the primary series of 12 to 15-year-olds, we reviewed the Pfizer phase 2/3 randomized controlled trial, which included around 2,000 12 to 15-year-olds in the US. We evaluated all eligible randomized participants who received vaccination as randomized within the predefined window and had no other important protocol deviations with a data cutoff of March 13th. Next slide. The clinical trial for the Pfizer vaccine demonstrated efficacy against symptomatic lab-confirmed COVID. There were no COVID cases among 1,000 vaccine recipients and 16 COVID cases among 972 placebo recipients for a vaccine efficacy of 100%. The GMR for antibodies in the 12 to 15-year-olds compared to what was seen in the 16 to 25-year-olds was 1.76, which means it met the non-inferiority criteria. There were no hospitalizations due to COVID or cases of MIS-C reported by any of the trial participants. Next slide. Then for potential harms in the clinical trial, the serious adverse events were reported at a higher proportion of recipients of the vaccine versus placebo, with 5 SAEs in the vaccine group and 2 in the placebo group, but none were deemed related to the vaccine. And none serious adverse events were more common in vaccine recipients, with a grade 3 or more reaction reported by 10% of the vaccinated versus 1.9% of the placebo recipients. Next slide. Then as we think through what we know about booster doses, and real-world effectiveness data from Israel, which followed 4.7 million booster-eligible individuals 16 years of age and over, booster doses given 5 months after a 2-dose Pfizer vaccine primary series demonstrated efficacy against confirmed infection in all age groups. Among the 16 to 29-year-olds, the rate ratio for infection comparing the non-boosted group to the boosted group was 17.2. Next slide. Then this data is from the Israeli Ministry of Health website. We heard updated information from Dr. Alroy earlier. But if we look at available information across all populations as of December 15th, you can see that myocarditis rates reported after the Pfizer vaccine in Israel suggest that the rates of myocarditis after a third dose are lower than what is seen after the second dose. Next slide. Previously, they had reported no cases of myocarditis out of 6,000 doses administered, and we heard earlier today that with over 40,000 doses administered, they've had 2 cases of myocarditis in this age group. Next slide. So then highlighting what we know about the impact of the Omicron variant. This slide was presented to ACIP at the last meeting, but in smaller studies that have looked at neutralizing antibodies of vaccinees, neutralization was below the limit of detection for those who received a primary series, either 2 doses of mRNA or 1 dose of a Janssen vaccine, and it moved above the limit of detection for those who either had a booster or had had previous infection. Given limits of detection of the assays and a lack of correlative protection, we don't know exactly what these antibody titer levels translate to protection for either infection or severe disease. Next slide. Then this slide was also previously shown to ACIP and is based on data from the UK. VE with the Delta variant is shown in the box and Omicron in the circle. On the left is a Pfizer primary series, and you can see that there's some waning for both variants over time. It appears to be more pronounced with the Omicron variant. Then on the right, you can see VE with a booster of either a Pfizer or Moderna vaccine. Again, while there's difference by the 2 variants, you can see that a booster of either mRNA vaccine improves VE with both Delta and Omicron. Next slide. So as we think through the potential benefits of a booster dose in those adolescents 12 to 15 years of age, we know that a 2-dose primary series of a Pfizer vaccine provides protection against symptomatic COVID infection, hospitalization. Now we have data around MIS-C. VE after the primary series is high, but likely is impacted by the Omicron variant. In persons 18 years of age and over in the UK, VE was lower for the Omicron compared to the Delta variant. However, exact estimates of VE against Omicron in adolescents 12 to 15 years of age is unknown. And booster dose has been shown to increase both neutralization antibody level in VE in persons 18 years of age and over. Again, in the UK, a booster dose increased the VE, specifically in the setting of Omicron. Next slide. Then when we think through potential harms, overall, the myocarditis rates among 12 to 15-year-olds after a primary series are lower than compared to what we see in the 16 to 17-year-olds. In addition, if we look at the Israel data, they had no cases of myocarditis after 6,000 doses, and again, 2 cases after over 40,000 doses. We know from experience in the older age groups, the rates of myocarditis after a booster dose are lower than what is seen after a second dose. Next slide. So in summary, in the setting of Omicron, we likely have lower vaccine effectiveness in all populations compared to what we've seen with Delta. Higher antibody titers improve neutralization of Omicron variant, and booster doses of COVID vaccines can increase those neutralization titers. The impact of a booster dose on neutralizing antibody, or VE, in adolescents 12 to 15-year-olds specifically is unknown, but it's likely to provide additional protection. And myocarditis rates after a booster dose are likely lower than what was seen after a second dose in younger adolescents. Next slide. So moving to values and acceptability. Next slide. Vaccine uptake among teenagers increased rapidly initially, but has stalled somewhat over the last few months, where around half of parents of children 12 to 17 said their teen has been vaccinated for COVID, and recently around 1% said that they plan to do so right away. About 1 in 8 parents said that they want to wait and see how the vaccine is working, and notably around 30%, or 3 in 10, said that they would definitely not get their 12 to 17-year-old vaccinated for COVID. Although while this data indicates a slowing of vaccine uptake among teens, note that the survey was conducted prior to the emergence of the Omicron variant, And as more information emerges on the potential impact of this variant on children, parents' attitudes towards vaccinating their teenagers or their younger children may change. Next slide. So if we look at vaccination coverage and intent among 3 age groups, adult, the adolescents, and the younger children, you can see that from October to November, almost 80% of adults were vaccinated against COVID, and around 13% reported they were reluctant to get vaccinated. By contrast, for the 12 to 17-year-olds, coverage was almost 60%, with around 20% of parents saying that they were reluctant to vaccinate their child. For those 5 through 11, 8% were vaccinated, 33% said that the parents were definitely planning to vaccinate their child, and a quarter were reluctant to vaccinate. And again, the survey was conducted in November, shortly after recommendations for the 5 through 11-year-old age group were issued. Next slide. Then this looks at behavioral, social, and access-related factors by vaccination coverage and parental intent for adolescents 12 to 17 years of age. This slide shows that parents of adolescents who are concerned about their kids getting COVID, are confident in vaccine safety, or have a provider recommendation to vaccinate their child, are more likely to be vaccinated or willing to be vaccinated soon. Parents who are reluctant to vaccinate their child are significantly less confident in vaccine safety and report less vaccinated social networks. But important to note that across all groups, they reported that they did not have difficulty or would not have difficulty getting the vaccine for their child. Next slide. If we look at parental confidence in vaccine safety, parents are less likely to express confidence that the COVID vaccines are safe for their adolescents or children than for adults themselves. Next slide. Then this slide shows the top safety concerns among parents of children 12 to 17. Respondents were instructed to choose their main safety concern around COVID vaccines. As illustrated, the most prominent safety concern among parents was the potential unknown long-term side effects. Next slide. So in summary, vaccine uptake among 12 to 17-year-olds for a primary series has slowed somewhat over the last few months. But as more information emerges on the potential impact of the Omicron variant in children, parental attitudes may change. But we know that parents of adolescents and children are concerned about the potential long-term side effects. Next slide. So moving to feasibility and implementation. Next slide. As of January 1st, roughly 8.6 million of the 16.7 million children or adolescents 12 to 15, which is around 50%, have completed the primary series. Around 5 million adolescents were vaccinated more than 5 months ago and therefore would be eligible for a booster dose. Next slide. Again, as we said, around half of this group is fully vaccinated. Based on our booster experience with other groups, we may anticipate around a third of adolescents who may return for a booster dose shortly after the recommendation. We know that supply of the Pfizer vaccine is robust, and the gray cap that was described earlier will be easier to distribute and administer. We know that currently demand for pharmacy appointments is high, and broadening eligibility could strain this further. Next slide. So now moving to equity. Next slide. Looking at vaccination coverage and parental intent for children 12 to 17 by race and ethnicity, you can see that there was variation where Hispanic children were more likely to be vaccinated than either Black or white children. Next slide. Then this slide illustrates vaccination coverage and parental intent by some county-level factors looking at social vulnerability index, or SVI, and county-level urbanicity. While there were no significant differences by the county-level SVI, those in urban and suburban areas had higher vaccination coverage rates than those residing in rural areas. Next slide. So in summary, there were noted disparities in vaccination coverage and parental intent by both race and ethnicity and geographic location. Next slide. So in summary, next slide. Dr. Daly highlighted we had a combined workgroup and VAST meeting yesterday. I'm providing a summary on behalf of VAST, but this represents their interpretation. VAST reviewed the most recent data for the 3 U.S. safety monitoring systems, including data on safety after the primary vaccination series in 12 to 15-year-olds, and after booster doses in 16 to 24-year-olds, the youngest age group for which booster doses have been authorized. No new safety signals were concerned or concerns were identified. And at the present time, data did not suggest safety concerns regarding a Pfizer vaccine booster dose for 12 to 15 years beyond what has been identified in the older age groups. Next slide. So now for the workgroup interpretation. The workgroup felt, again, the top priority remains vaccination of unvaccinated individuals. The benefits of the COVID vaccine primary series outweigh the risk in all age and sex groups, as the primary vaccination series remains the best tool we have against COVID hospitalization and death. Then as we think through all COVID vaccine recommendations, we want to highlight the goal of the COVID vaccine program to prevent severe disease, including hospitalization and death. We have secondary goals as well: maintaining workforce and healthcare capacity, reduce infection rates and risk of transmission. Then as we specifically think through what may be relevant for this adolescent population specifically, a greater confidence in in-person learning, improved mental health with more social interactions, and prevention of post-COVID conditions. Next slide. Overall, the workgroup supported the use of boosters in adolescents 12 to 15 years of age. The workgroup emphasized the importance of clear and consistent recommendations for all adolescents, including those 16 to 17, so for the combined age group of 12 to 17 years of age. And as we have seen over the many ACIP meetings over the last year, vaccine recommendations can and will be updated as needed, especially in a rapidly evolving pandemic. Next slide. So this slide highlights the balance we've used for previous booster dose recommendations. ACIP cannot recommend the intervention. ACIP can recommend the intervention based on the balance of benefits and risks, which we've used as the may recommendation. And ACIP recommends the intervention, which is the should recommendation. Next slide. So the workgroup discussed the recommendation that adolescents 12 to 15 years of age may receive a booster dose based on the individual benefit and risk. This recommendation acknowledged limited data directly on the impact of boosters in the adolescent population. However, in the current Omicron surge we're experiencing, it provides a recommendation for boosters in a population that could have waning immunity, both due to time since primary series and the impact of the Omicron variant. The workgroup also discussed the possible advantages of a recommendation for adolescents 12 to 15 years of age that they should receive a booster dose. The workgroup discussed the difficulty in defining that individual benefit-risk balance with the may recommendation and how it can be difficult for vaccine providers to communicate. In addition, in the current Omicron surge, prevention of infection may have larger benefits that are difficult to measure. Mentioned earlier, the population level protection, school attendance, mental health impact. Next slide. Then highlighting that this is the slide, highlights language that was previously in clinical consideration around what individuals and providers could consider as they think through that benefit-risk balance with a may recommendation. Next slide. So again, highlighting the policy question for ACIP to discuss today: should individuals 12 to 15 years of age receive a Pfizer vaccine booster dose under the current emergency use authorization based on the balance of benefits and risks? Next slide. Next slide, I think there are two in there accidentally. Before we move to ACIP, I again want to extend my thanks. This did require substantial work over holidays. So the people on this slide, as well as the additional teams, we had Epi Task Force, Vaccine Task Force, our Data and Analytics Task Force, individuals in our respiratory virus branch, many of which who scrambled very quickly to get us data, not only in a short period of time, but over holidays. So want to extend my personal thanks to the people represented on this slide to make this presentation happen. Next slide. So then I think, Dr. Lee, as I turn it over to you, I want to pose these questions to ACIP. What does ACIP think about the recommendations for booster doses of the COVID vaccines in adolescents 12 to 15 years of age? what are the ACIP thoughts around the may recommendation, and then the ACIP thoughts around the should recommendation. Thanks.
Thank you, Dr. Oliver. I really appreciate your going through that complex discussion and a rich set of decisions ahead of us. I want to open this up to questions focused on what Dr. Oliver has on this slide. And so would invite our ACIP members to ask questions or provide comment. Ms. McNally.
Thank you. Dr. Oliver, just pointing back to slide 41, please. Is there anything that you can say to the public right now to allay concerns regarding the potential unknown long-term side effects?
Thanks so much. I do think we can highlight that we've had recommendations for adolescents, this 12-year-old population, since May. We've had extensive post-authorization safety surveillance in this population. We've had millions vaccinated. We did identify, so I even went back earlier today and looked. We had the recommendation for 12 to 15-year-olds mid-May, and the ACIP the ACIP meeting on myocarditis mid-June. So that's how quickly we rapidly identified and brought this to ACIP. The rates for the myocarditis that we've seen have actually been stable really over time. So I think we've identified that quickly. We know and understand that. And then we've been watching for months and have continued to see that VE is high. We know that this is the best tool to prevent COVID-associated disease, hospitalization, and death. So we continue to get more information. We see the continued benefits. We know now that it can prevent hospitalization with MIS-C. And so I think I would just continue to say we're conducting rapid, extensive post-authorization safety that has demonstrated that these vaccines are safe and effective.
Thank you so much, Dr. Oliver. And I understood, I think, from your presentation, the acceptability surrounding the vaccine in general, but is there any specific information regarding the acceptability of a booster in this age group?
Thanks, Ms. McNally. So we tried. I think ultimately, since the information about the potential for boosters was only announced a couple of days before the meeting, we weren't able to get a rapid survey out there. So we'll continue to follow, but we don't have specific information around acceptability. As I mentioned before, if we look back through what we've seen as the booster recommendations have evolved over time, there is a cohort, about a third of the eligible population that goes right away. So I think we're anticipating we may see something like that for the 12 to 17-year-old population as well, but we'll continue to follow.
Appreciate the information.
Thank you. Dr. Paling?
All right. Dr. Oliver, I want to say thank you to you and the entire team for pulling all this data together. And one of the things that really struck me was the hospitalization rate. And if there's any chance you could, it was early on when you zoomed in on the children, could we pull that up?
This slide, or you want the next one? Okay, slide 12.
And so what struck me about this slide is that you can see the 0 to 4s are clearly higher, and they're the ones where there is no vaccine recommendation. And then I believe you pointed out that hospitalizations were 11-fold higher among the unvaccinated. So definitely demonstrating how the 16 to 17-year-olds, as they've had increased vaccination, their rates are coming down on hospitalizations. As I'm sitting here thinking about the questions that you ask, we have a hospital that's full, and we have of COVID across all ages, the unvaccinated being far more representative, and we have children waiting in the ED 18 hours and longer just to get into the hospital because we're so full. We also have parents that are asking us, can their children get a booster dose like
older children. And so as I'm looking at this and as we're looking at how transmissible this is, I am leaning towards should. Over.
Thank you, Dr. Kaling. Dr. Sanchez.
Thank you. As I think about the may or the should, the 16 to 17-year-old is still a may, is it not?
Dr. So actually, thank you very much for pointing this out. And I don't want to get ahead, but I think I can say, if you guys decided to go with a may, you could vote on 12 to 15 may. I think if you guys decide to go with should, then the vote would likely be 12 to 17 should, so we can make sure that the 12 to 15-year-old is harmonized with the 16 and 17. So thank you for letting me clarify that. You're right. Right now, 16 and 17 is may. So if you moved to should, we would move the 12 to 17-year-old population together.
Dr. Zimmerman.
Speaking as a vaccine researcher over the decades, the human immune system responds well to boosters. Therefore, personally, I support should. Over.
Thank you. Ms. Bata.
I too support should, but I do want to pontificate a little bit. I am so concerned that the burden of disease prevention is all falling on the vaccinated and them getting the boosters, and that we, as I heard from one of the epidemiologists at WHO, we cannot get through this pandemic through boosting, and yet I understand that we need to be able to use every single tool in our disease prevention book. But I would really like to see much more clear direction to the general population about the other measures to prevent disease spread. No, I rarely see people masking anymore, especially indoors and gatherings. And to me, that is such an important adjunct to the tool of vaccination. And so I just need to get that out, that we can't put all of the burden on the people that are willing to get vaccinated. And when we only have half of our adolescents vaccinated, that adds more burden as well. But I do lean towards should. Thank you.
Thank you, Ms. Bata. Dr. Kimberlin.
David Kimberlin. This following comments is my own alone. I'm not speaking on behalf of the AAP. I've heard the question raised at prior ACIP meetings and among other experts around the country of what we're really asking of these vaccines. And I think that we need to fundamentally first pose that question again. Are we asking the vaccines to prevent every runny nose? Or are we asking the vaccines to prevent hospitalization and death? And if you look at slide 20, I believe, of Dr. Oliver's slide set, at least, during the Delta period, the vaccine effectiveness was looking really, really good. These vaccines are working in what I would suggest is the only reasonable and possible way that they can. I don't know of any vaccine that can prevent every respiratory infection, symptomatic or mildly symptomatic or asymptomatic. So I would suggest a refocusing on what we want from the vaccine prior to deciding whether boosters would get us there. Thank you.
Thank you. Dr. Maldonado.
Yeah, thank you very much. And again, this is my own personal opinion based on my interactions with my colleagues across the country. I really understand what Dr. Cotton mentioned around who's getting sick and the complexity and the tragic circumstances that we're seeing in these immunocompromised kids. So, but at the same time, we are still seeing a number of children who don't have underlying conditions who are being hospitalized as well, and who are contributing to household transmission and school transmission. So one of the areas I wanted to bring back, and also since Dr. Kimberlin brought back refocusing, which I agree with, and what Ms. Bata said as well, is we really need to start thinking about ways to reboost, no pun intended, our efforts to get people back to the basics. I know we're all tired. We are, our staffing issues are deplorable at this point. We're seeing record numbers of people out of work, and, that may, quote unquote, be expected from a bad cold virus, but we're also seeing our kids being affected. We have record numbers of cases in kids now, record numbers of hospitalizations of kids, and the deaths are going up. It still is in the top 10 causes of death for children in this country. We can't forget that, and that is a really important area to emphasize. The fact that less than 25% of 5 to 11-year-olds have been vaccinated yet, and that only half of our adolescents are vaccinated at this point, I think is really critical. And obviously, I think a booster is important, but we need to really base that booster on reinforcing the need for vaccinations for others, for masking, distancing, et cetera, because we're seeing the consequences of this whole pandemic. It's not just the vaccine, but it is one tool in getting our kids back to school, getting them back into society. And we're seeing the overflow here, where school districts are now shutting down, teachers are refusing to go back to school, et cetera. So I think overall messaging can be based on vaccines, but we need to broaden that out and make sure that to protect our children in every way we can, we need to really reemphasize the safety that we need to take to keep them protected. And vaccines are one very tangible way to do that, but there are others as well. Thanks.
Thank you. Dr. Long.
Yes, I couldn't agree more with Dr. Kimberlin that this is a hospitalization and death vaccine. Anything else we ask of it is over the top. And although a booster dose may get that kind of antibody for a very short period of time, that may give some protection against symptomatic infection, that will not last. And it will probably give no protection against asymptomatic infection. So I think that we are getting enamored of the Israeli study, for instance, showing that boosts were, a decreased infection rate, and that's not what we're going to be able to accomplish. However, on the other hand, we're right in the midst of this new phase where children are affected. And children are affected in large numbers, and that I think until we get past this peak with Omicron, I'm very much in favor of should boosting, and that this will help us understand over time whether it does, if there will have been any protection against hospitalization and death for those who are otherwise fully vaccinated. I think we have no information that is happening. We do know what the antibody titers look like. I think it will allow us to whack-a-mole for another month or two, but this is not sustainable, and it's not smart to think that we have to continue to boost to prevent infection or mildly symptomatic infection, because it just isn't going to happen unless everybody in the country gets Omicron and we then transition to an endemic, less severe disease. So I'm in favor of should for this age group as the last whack-a-mole.
Thank you, Dr. Long, and appreciate everyone sharing their input on this difficult topic ahead. Dr. Talbot.
I'm gonna
disagree just for the reasons of the limitations of the current medical care system. I feel like if we say should, that's going to turn many providers into going back, and we really need to move forward. We need to get the other 50% of the 12 to 17-year-olds, and we need to get the other 75% of the 5 to 11-year-olds, and that really should be the main concern. It's nice to have that booster in the 12 to 15-year-old to prevent, illness, but most of them will be safe after 2 vaccines from a severe illness. And that if we spend the time making those may shoulds, we may lose some of our 5 to 11-year-olds. So I really, if we had a really well-funded public health system that had the capacity to do everything, I would say, yeah, should be great. But I really think we need to focus on the 5 to 15-year-olds who aren't vaccinated. Thanks.
Thank you. Dr. Sineas.
Yes, I also agree with the need to double our efforts to reach the unvaccinated. But given the current state of the surge, I'm also leaning more towards a should than a may. And I do think that the language should align with the older age group, the 16 to 17 years old. But I also have a question about, given the surge that we're having, we are seeing patients in the 12 to 15 age group who've been vaccinated who are now having breakthrough infections. Is there any guidance on the recommendation for boosters for those patients in terms of timing after a recent infection? Or will there be a recommendation?
Dr. Twyman or Dr. Oliver?
Yeah, thanks so much. We don't have, the only recommendation that we have specifically around recent infection is if you are, during the time period that you should be actively kind of quarantining or isolating, please don't go get vaccine then, as we just don't want you to be waiting in line at Walgreens, if you just tested positive that day, because it would potentially, put the vaccinator staff at risk. But otherwise, there's no, specific minimum interval between recent infection and time that you could get a booster dose.
Dr. Hogue?
Thank you, Dr. Lee. This is Michael Hogue with the American Pharmacists Association. This is maybe one of the toughest questions that I think we have faced recently. And I know we've had a lot of really tough questions, but I'm personally struggling deeply with the may versus should. I'm struck particularly by Dr. Kimberlin's comment about what is it we're trying to prevent here, and it's hospitalization and death. We do see breakthrough infections to the previous comment. I think that we have to acknowledge that in the adolescent and adult groups, the majority of these vaccine doses are being given in pharmacies. And you all are probably aware that there is an increasing severe shortage of staff personnel in pharmacies, both of pharmacists and of pharmacy technicians. And the amount of burnout that's happening in those practice sites is pretty significant. I think that when we have limited resources, as Dr. Talbot has said, we have to think about what is reasonable to ask of our limited resources to be able to accomplish. And I think that while in an ideal world where everything is funded the way it should be funded and we have no shortages of healthcare professionals, a should might be okay, but frankly, the hospitalization rate, I realize that every hospitalization is one too many and every death is one too many, and we want to do our best to prevent it. But the hospitalization rate and the death rate among the adolescents in this age group are very, very low compared to the older adult age group that we have made stronger should recommendations for. And so I think, as a result of all of these things, stress on the existing system, the
small numbers of people who we are seeing in these age groups that are hospitalized or dying from COVID, I think it's premature to go to a should statement at this point. It could change in the future, and therefore I would support and recommend a may recommendation for this age group.
Thank you. Dr. Lair?
Thank you. I'm surprised to be in favor of the should recommendation because I usually think that we go too much in favor. I strongly support Dr. Long's and Dr. Kimberlin's perspective. Having said that, I see this as a surge that is greater than other surges. I see the number of cases as tremendously higher. And just by the volume of cases, I would see a large number of people ending up in the hospital. And that is what is concerning me. So I would go with Dr. Long's whack-a-mole analogy of let's whack this one down and reevaluate in the future, but I'm in favor of a should recommendation.
Thank you. Dr. Sanchez?
Thank you. I also, I'm torn. But I definitely agree with the colleagues, and that we need to make sure that the message is to prevent serious disease. And I think that that's been a fault from the beginning of the vaccination program. And I think it has, the talk of preventing just a regular infection has contributed to vaccine hesitancy. So I think we have to be clear that that's it. On the other hand, in terms of the may or the should, I become concerned about the should and what does that imply and what does that ultimately say. So is the should going to bring more vaccine mandates? And will it change what we consider to be fully vaccinated individual, which would be down to age 5? But at the same time, my struggle is that I believe in the vaccine. I believe that it has been safe. I believe that we can prevent serious infection. And with this Omicron surge, even though it seems to be less severe and certainly less severe among the vaccinated individuals, this vaccine, the messenger RNA vaccines, do work. And there is some waning of the antibody responses. So I think we can make the overall situation better by actually endorsing a vaccine that I personally believe in. And so I'm really, despite my struggle, and I'm sorry that I'm going on, I ultimately think that we should come out with a more forceful recommendation and go with the should. Thank you.
Thank you, Dr. Sanchez. I'm going to call on Dr. Amanda Cohn for a moment.
Thanks, Dr. Lee. I just wanted to, Dr. Sanchez brought up this issue of whether or not a should versus a may would change potential mandates. And I just want to remind the committee that, the federal government we don't make school mandates. That happens at the state and local level. And so we should really try to keep that not as a consideration in terms of making these decisions. But I also just want to clarify that I think it was yesterday, we updated our guidance around the fully vaccinated to use language that says up to date. May have been today, I'm sorry, I'm getting my days confused. But so we're now using language that says up to date, which allows us to include booster dose recommendations based on time since an individual got vaccinated last, so that word fully vaccinated really just applies to the primary series, and we should really be focusing on making sure that everyone is up to date. Finally, as I very rarely bring my personal opinion into this, but as a parent of 3 kids in these age groups, I just want to say that I do think that understanding the, there's so much burden and stress on everyone, but I do think that there's been a particular challenge in this age group in terms of kids being isolated and having problems with depression and anxiety and challenges when they're sent home from school because they were positive or can't go back to college because they're positive. And so I think all of those sort of immeasurable potential impacts of a booster dose, fully recognizing that it may not eliminate transmission, but it may even reduce the potential for a child to be positive or to be infected, could have a larger immeasurable impact on the well-being of these kids.
Thank you, Dr. Cohn. Next, we'll go on to Dr. Cotton.
Thank you. I'd like to second what Dr. Cohn just said, and I strongly agree with her comments. I would like to speak in favor of a should recommendation. I am seeing many families where there is transmission from children to adults, and in some cases there are devastating outcomes. So I think as much as we can prevent what might be mild to moderate disease in children, but as much as we can decrease disease in families, I really think that that's the way to go. I think that the impact on a child who brought illness into a home and it sometimes results in the death of a parent or a grandparent is absolutely crushing. I'm seeing this clinically, and I think that the more clear we can be in our recommendations, it's really, really helpful to those of us in the clinical trenches. Also again, to protect the immunocompromised patients, protecting children who are really one of the major ways that people are being exposed these days will really help prevent disease in immunocompromised patients as well. So I'd like to speak in favor of should. Thank you.
Thank you, Dr. Cotton. Dr. Brooks?
Yes. First of all, excellent meeting. I think that it's really important that we're having these deliberations, these discussions, because we are all hearing this in real time. So this information coming in is actually affecting how we are thinking and how we are theoretically going to vote, I think. I would speak in favor of should. Now, we're looking at this ultimately from benefit-risk ratio. And it's interesting because to me, the benefits are unknown, but the risks are known. I mean, we don't know that if people get boosted, will they help them with the next variant? But it probably will help in some way. So it's a good unknown. School attendance, we do know that it will likely affect that. That's important. Transmission, we don't know, but we believe that it may help with reduced transmission, both to other children and to adults. We do know that it will reduce hospitalizations and death, though to what degree, it's not that high, because the death and hospitalization rate is not that high in this age group. But looking at, like slide 51 said, the primary goal is the reduction of hospitalization of severe disease. So when people were talking about what are we looking at, the work group said severe disease. So that is what we are looking at. And then one other thing, maybe there are people that are immunosuppressed that don't even know it that are going to get this booster. And so it will protect those that even have unknown conditions. Now, the risk we know is myocarditis, but we didn't even discuss in this particular deliberation that if you get COVID, you have more of a chance of getting a severe myocarditis. So I think that is mitigated. So lastly, this is one tool in our toolbox, and I think that we should, if it's a hammer, we should hit that nail hard. And so I am in favor of a should recommendation.
Thank you, Dr. Brooks. Dr. Paling.
I would like to follow and agree with my colleagues about the should. I think we need to highlight that children are not okay. Our hospitals are full, and it is true that children are hospitalized at a less frequent rate than adults, but it is COVID is overwhelming our hospitals and our children's hospitals. And as Dr. Donato emphasized, COVID-19 is a top 10 cause of death among children. And so this is not benign. As Dr. Brooks just mentioned, children with COVID, we are seeing myocarditis and severe myocarditis and we're very worried about the MIS-C to come. The other thing is, I too am seeing children who have lost parents. And so when they are quarantined, this creates undue stress and hardship on them and their families. And missing school is a big deal. And so I think this is a tool we need to use and help our children through this pandemic. Thank you.
Thank you. Dr. Talbot?
I'm a little worried about how we're talking about the kids who are in the hospital. And I need someone who is familiar with the EPI to explain this to me. Are the kids that are being hospitalized for COVID vaccinated or unvaccinated? Because if they are vaccinated, that makes a big difference in the use of the boosters. It should be a should at that point. But if you're telling me the kids that are being hospitalized are unvaccinated, it means we need to spend our days and nights vaccinating those that are unvaccinated. So if someone could just answer that question, it'd be great.
Hey, Dr. Talbot, this is Dr. Oliver. I mean, I think we can definitely, I think there are vaccinated kids who are in the hospital. We know that the highest risk is in the unvaccinated. So if we go, I can't remember the exact slide.
It was a beautiful slide that showed it was the
slide 14. Slide 14. So, I mean, it's not zero, it's low among the fully vaccinated 12 to 17-year-olds. So it's not zero, but definitely the highest risk is the unvaccinated and fully.
So I think in response, Dr. Oliver, I think what I'm trying to say, and sorry to cut you off, is that this booster will not be a hammer. This booster is going to get the nail in a millimeter, and then there's 20 millimeters that need to go in that this hammer is not going to work on. And so I guess that's my thought, that if we divert our public health from the unvaccinated to the vaccinated, we are not going to make a big impact. Boosters are incredibly important, but they won't solve this problem of the crowded hospitals. That's going to be the unvaccinated. Thanks.
Thank you. I'm actually going to jump in. I recognize there are many hands raised, and I'm really grateful that everyone is, sharing their opinions. I wanted to just start out by, I agree with nearly all of the comments that my colleagues have mentioned, but I did want to state a different opinion, which is that I actually think we are trying to prevent infections and not just serious disease and hospitalization. This is not dissimilar to the reasons we also continue to use tools like masking and testing. We are trying to reduce the risk of infection to protect ourselves and others. I also think that we have burdened an entire generation of children, whether or not they're infected, with the impact of COVID. And I certainly think that infection and transmission are impacting our ability for individuals to function. So keeping our schools open, keeping hospitals open, keeping businesses open, keeping communities open, all of this to me is critical. I see vaccines as not the only solution, but one part of the broader public health conversation we need to continue to have around vaccines, masking, testing, et cetera, for us to be able to manage through this pandemic. So I wanted to just make sure we are, at least that I got my opinion in, that I don't think it's just about hospitalizations and death. I truly think it's about the entire picture of our kids in terms of not just their physical health, but their mental health, their social emotional functioning, their academic development, et cetera. And I also truly believe we have not yet addressed the long-term impact of COVID infection in children. I think we haven't even scratched the surface of what we're going to see. And so, I would say that we continue to need more data for sure. And I'm just hopeful that others will also perhaps consider prevention of an infection a worthy goal. I want to call on our ACIP members, and I have our liaisons who also want to weigh in. We want to make sure we get to everyone. So I think I have Dr. Sanchez, are you next?
I did have another comment. But,
okay, go ahead.
Although and I had another comment, but I'll just make that we all want to prevent infection, but I think the current vaccine is really showing us that it's more for serious infections. I think in this should versus may, and I understand the problems with implementation of a booster and all of that, but I do think that we need to do what is best for those families and children who want to be vaccinated and who do want to be as protected as possible. So I think that that a should will allow that to happen as well, and also with our with a stronger recommendation. I mean, there may be implementation issues that we've heard, but I think that that we need to do what is best. And then I had a question, and maybe not now is not the best time, but I'm still a little bit. I was confused a little bit by the up-to-date change, and that could be done later. But I was a little bit confused about the current statement on up-to-date versus fully vaccinated.
Thank you. I don't know if Dr. Cohen or somebody from CDC wants to respond, or if I can take a couple more questions first and then come back to our CDC colleagues in case there's something that they can share or show.
Yeah, take a couple more questions.
Okay, thank you. Let's go to Dr. Paling.
Yes, thank you. I greatly appreciate this robust discussion. And as I'm thinking about it, we have a similar, I'm appreciative of the slide that's on here showing the difference in unvaccinated versus vaccinated hospitalizations. This is similar to what we see in adults, and we have a should recommendation for adults. I believe that having the same recommendation across the age groups is the way to go and improve clarity of communication. Thank you.
Thank you, Dr. Paling. Dr. Daly.
Yeah, thanks so much. I'm going to make 3 comments, and they're a little bit disparate just because I've been trying to sort of listening in and thinking hard about what's been said so far. So actually, first, I'm going to go way back to a comment that Ms. McNally made about what's known about long-term safety. It's a great question, and this in some ways is directed to parents of unvaccinated kids. But I think, decades of experience with vaccines has shown that for the most part, if they cause side effects, those are in the short term. But I would sort of keep in mind that when we met in August of 2021 to review the BLA for Pfizer, at that point, we had 12 months of safety data from the individuals or maybe not exactly 12 months, but nearly 12 months of safety data. And we vaccinated several 100 million adults since now. So we have more data that's reassuring about long-term safety than we would typically have for any other routine childhood vaccination. So we never know everything about long-term safety, but what we know to date is really reassuring. And we have longer-term follow-up because, those clinical trials were conducted in the summer of 2020, and then we met in August of 2021 for the licensure for Pfizer. So that provides reassurance to me. In terms of should versus may, I certainly I would vote in favor of either. Although I've been thinking about whether this really perhaps may have been a 3-dose series all along, and if that is the case, then I would be in favor of a should recommendation. I think 2 doses spaced very closely together was dictated by the pace of the pandemic. And then the observation that immunity was waning came later, and we had to do that at the time. But it may have been that this was a vaccine that all along needed a booster to achieve the best vaccine effectiveness we could achieve. So a third point is that I don't think a should recommendation in 12 to 17-year-olds is going to take away from our public health focus on vaccinating the unvaccinated. I think the hard thing is that everybody who is eligible, I think, could have received a vaccine by now, and so then that group is going to be challenging to convince, but I think we need to do everything we can. But I don't think should recommendation for 12 to 17-year-olds really takes away from that. And then my final point is that during the work group yesterday, we heard from one of the work group members who said, vaccinating 12 to 17-year-olds with a booster, if it prevents their lives from being entirely disrupted by testing positive, where they can't go to school and they can't be around their friends and they'll be very isolated in the basement of their house, that is, in that individual's view, worth it for boosters. And so we're mainly trying to prevent the most important goal is preventing hospitalization and death, but I feel like positive tests in mildly symptomatic disease in 12 to 17-year-olds is incredibly disruptive, and they've suffered greatly from the pandemic. Those are my comments. Thank you.
Thank you, Dr. Daly. I'm going to do a quick check-in. Does anyone from CDC want to comment, or can I go through the liaisons next? I don't hear anything. So I'm going to go through the liaisons really quickly. Oh, okay, go ahead.
Yeah, I can just quickly explain to Dr. Sanchez the up-to-date shift. So we're shifting to language that tells people, instead of we want people to be fully vaccinated, we want people to be up to date on their vaccines. So fully vaccinated implies the original 2-dose series of an mRNA vaccine or a 1 dose of a J&J, whereas staying up to date means that if you are eligible for a booster dose, or if you're moderately or severely immunocompromised, you should have additional doses. And so we're going to be over the course of yesterday and through the next several days, we'll be rolling out additional communications around this issue to start to get the community sort of to shift their thinking to encourage people to be up to date rather than fully vaccinated, since up to date is different depending on who you are.
Thank you. Okay, we'll go. I'm actually going to pause and ask Dr. Oliver if, given the committee's discussion so far, I think we should ask you to put up a vote that includes the language of should for 12 to 17. If you can change that 15 to a 17. That would be terrific when you get to the vote. And in the meantime, I'm going to ask for our liaisons to comment. Dr. Zahn.
Thank you, Dr. Lee. A couple of comments just from a local public health standpoint. Certainly, should recommendations are much easier to understand, to communicate, and implement than may. It's not an absolute reason why you make a decision, but it certainly makes the communication a great deal simpler. In terms of reacting to Omicron, a couple of comments. I think Dr. Daly's exactly right that certainly, any new recommendation is a potential stress, but if the ACIP thinks that this group should receive the vaccine, then we use the resources we can as well as we can to respond. I think that generally speaking, we're really in a testing capacity shortage right now as a country, right? More than an ability to immunize people, or vaccination capacity shortage. And so if it's the right thing to do, I think public health responds. I would say that for Omicron, the bigger concern is Omicron's in a hurry in an awful lot of communities. And so these are not waves in other countries or in what we're seeing here that we think are going to be lasting months. And so I wouldn't put too much emphasis on saying we're going to get people boosted to get them through Omicron. I think you should more think in terms of what is the utility of having this population boosted, anticipating that there will be virus, Omicron and other viruses, new variants around in the future. And I do think that it's been said a couple of times, but can't underscore enough the disruption of COVID in general to schools, but Omicron in particular to the school situation is a very significant issue. This has been going on for a couple of years. We got to figure out ways to keep our kids in school. And so any measures that we have that will make our schools safer, make it easier for our schools to stay open during this and current surges is well worth considering. Thank you.
Thank you. Ms. Stinchfield.
Thank you, Dr. Lee. Patsy Stinchfield, National Association of Pediatric Nurse Practitioners. I support the should for much of this wonderful conversation, especially your comments, Dr. Lee and Dr. Cotton. So individual protection and societal. Secondly, how do we vaccinate the unvaccinated? I really think in this age group, we just have to get it into standard work like we do other vaccines for people entering schools and universities and make it an entry requirement. And I don't think it's too early to start working on those things even for next fall. And I think as one of our public commenters said, engaging school nurses early and working with education boards and legislators, those conversations should be happening now. And then last, I shared Kathy Paling's concern about the slide with the 1 to 4 year or 0 to 4 year old hospitalizations being so high, and that age group being unprotected. That's probably the number one question that I get from parents is when. And so when the time is right at this meeting, before maybe after the vote, Dr. Lee, if somebody could just give the public a quick update on that timeline, that would be wonderful. Thanks everybody for your dedication here.
Thank you. Dr. Rockwell.
Thank you, Dr. Lee. I'm Pamela Rockwell, American Academy of Family Physicians Liaison. So I just want to speak as a family physician, as my AAFP representative, that I support a should recommendation for several reasons. One is to keep the CDC recommendations clear, concise for physicians and other vaccine providers, as has been stated. I am regularly surprised by anecdotal, misinformed guidance my patients have received from other healthcare professionals in my community. Two, in addressing the current state of our compromised and overburdened healthcare force, as we currently see, as another previous speaker spoke about, a should recommendation may result in fewer infections, as Dr. Lee and Patty Lynchfield just stated, result in fewer hospitalizations of both the vaccine recipients and their family members, and therefore a should recommendation may actually help reduce the burden on our healthcare force in a short amount of time. And lastly, in addressing those who have not yet been vaccinated, with plenty of opportunity to do so at this point, and much frustration from those of us who offer vaccinations, I agree with the previous speaker that our public health efforts will not be compromised by this should recommendation, as I don't think it will take away from any efforts to vaccinate the unvaccinated. I believe we need to explore other and different efforts to exchange the acceptance of vaccination for the current unvaccinated population. Thank you.
Thank you. Dr. Duchin?
Thank you, Jeff Duchin, Infectious Diseases Society of America. A should recommendation clearly has advantages in the context of simplicity, clarity, and consistency with other guidance. And I think that the discussion indicates that the ACIP voting members are favoring that. I do want to say, though, that if there were to be a May recommendation, it would need to be very explicit in order to give the public and our healthcare providers and our public health vaccine administration programs the guidance about under which circumstances a child who may get it should get it. I mean, how would we make those decisions? That would need to be part of a May recommendation. I think that this discussion clearly does not, or today's decision is not informed by the amount of data that any of us would like. And it's an example of real world, real time, and real tough pandemic decision making. And I commend the ACIP members for the excellent discussion and the thoughtful deliberation. I do think, though, we need to get back to what I believe Dr. Kimberlin mentioned at some point, which is to explicitly define the goals of our national COVID-19 vaccination program with respect to prevention of infection versus serious disease. And I anticipate that can happen once we're out of the acute crisis stage of these recurrent surge waves. But I think that should be an explicit topic when possible. Thank you.
Thank you. Ms. Hayes?
Yes, Carol Hayes with the American College of Nurse Midwives. I've heard from a lot of people that they're frustrated that the language coming from the CDC seems to change all the time on what the recommendations are. So I think that when this comes out, we need to continue to promote that as the virus changes, we have to change with what our recommendations are. And I do think that we need to have a conversation about what being fully vaccinated means, because there is some confusion in the public still about if you've had one J&J, is a booster making you fully vaccinated, and is 3 vaccines going to make you fully vaccinated? So that, I think we need to get a very strong message going out. What is being fully vaccinated? Thank you.
Thank you. Ms. Arthur?
Hello, Phyllis Arthur for Bio. I actually just wanted to talk about something that Dr. Cotton talked about. I think there's a lot of interest in better understanding the various symptoms and effects of COVID infection on young people. I think there's not so much clarity. I think people think it's milder than it is, and this group has a good understanding of that. So maybe an MMWR or some kind of publication that very clearly captures the various impacts of COVID itself on children in the various age groups. I think that would help also to make the case for why vaccine is so important in the unvaccinated group there. There may be this misconception that it's generally always asymptomatic or mild disease, and there have been circumstances with some of these more important side effects that are showing up in this age group that could help parents make a better informed decision.
Thank you. And Dr. Whitley-Williams.
Thank you. I was going to make some of the comments that have already been said, so I will not review those, but certainly recommending boosters in the 12 to 17-year age group is just one step in stemming the tide of this pandemic. And I do agree with Dr. Talbot that certainly the focus, one of the other steps that need to be taken is certainly to encourage people who are unvaccinated to become vaccinated. And having been on the pediatric ID service within the last 2 to 3 weeks, we are being overwhelmed, as has been demonstrated by children who are unvaccinated and from families who are unvaccinated, including mothers and newborns. The newborns have not been terribly sick, but we are starting to see that phenomenon. The second comment I had was in light of the noted racial and ethnic disparities in vaccine coverage and parental intent. Just want to remind the committee that there are still existent social barriers that do exist in communities of color. That is not an excuse, but it is a reality of the situation. However, I can assure you that the National Medical Association continues to educate its membership, primarily who are African American physicians, and provide care for persons in communities of color, as well as to educate the public and persons in our communities of color as well. Thank you.
Thank you so much. And Dr. Kim, you have the last word before we move to vote.
Well, thank you very much. I'm David Kim, OIDC. I would like to see if we can consider the perspective of the folks at the user end, that is the patients and the public. I'd like to ask, what is our message to the public? And what is our message to the parents of 12 to 15-year-olds and the 16 and 17-year-olds who are on the fence about the primary series or the booster series? As Dr. Daly noted earlier, we're basically at a 3-dose vaccination series, primary series. As such, echoing Carol Hayes and Dr. Duchin had said earlier, the committee has an opportunity and perhaps even an obligation to streamline and simplify and make concise its recommendations, strong recommendations that we're promoting the use of vaccines to control this pandemic and get the message out to the folks who are currently not vaccinated, and to ensure that we have a better chance of immunizing the community so that we can get a better handle on this pandemic. So I would just like to point out that we should make a strong, concise recommendation, and I do believe that that consistent use of should is the way to go. Thank you. Back to you, Dr. Lee.
Thank you so much. And I just want to highlight that what you said was that our recommendations are only the first step of this process, and that a lot rests with implementation and communication to ensure that there is, access, acceptability, and equity was mentioned, and we are extremely grateful to our liaison partners around the virtual table who have clearly supported the implementation efforts, recognizing how difficult it has been in this dynamic pandemic and the need to continually reevaluate, but appreciate the partnership and the collegiality. So now let's move to the vote. I'm going to ask Dr. Oliver to read the vote that is listed on the slide here. Dr. Oliver?
Thank you so much. The proposed language for the vote right now is a single Pfizer-BioNTech COVID-19 vaccine booster dose is recommended for persons aged 12 to 17 years of age, at least 5 months after the primary series under FDA's emergency use authorization.
Thank you. And actually, I see Dr. Alt has kindly put on his camera. I'm going to ask our other members to put on the camera and ask if any of our voting members wish to make a motion. I see Dr. Paling's hand was raised. Did you have a question or did you wish to make a motion?
I wish to make a motion. I wish to make a motion to accept the wording as is. Thank you.
Thank you. We have a motion on the table. Would anyone like to second the motion? Dr. Alt?
I will second the motion.
Thank you. It's been moved and seconded that we adopt the recommendation language presented here on this slide and read by Dr. Oliver. Are there any additional questions or concerns the committee would like to discuss before the vote? Okay, thank you. And I recognize perhaps not everyone can get their camera on, but we appreciate your presence. And for those of you who have your cameras on, thank you for joining. We'll go ahead and start with our let's start with actually Dr. Chen.
Yes.
Oh, and sorry, apologies. You should state your name, conflict of interest, and then your vote.
Wilbur Chen, no conflicts, yes.
Thank you. Dr. Daly.
Matt Daly, no conflicts, yes.
Thank you. Dr. Lair.
Amy Lair, no conflicts, yes.
Thank you. Dr. Long.
Sarah Long, no conflict, yes.
Thank you. Dr. Paling?
Kathy Paling, no conflicts, yes.
Thank you. Dr. Talbot?
Dr. Talbot, no conflicts, no.
Okay, thank you. Dr. Alt?
Alt, no conflicts, yes.
Thank you. Dr. Brooks?
Oliver Brooks, no conflicts, yes.
Thank you. Ms. McNally?
McNally, no conflicts, yes.
Thank you. Dr. Saneas?
Sybil Saneas, no conflicts, yes.
Thank you. Ms. Bata?
Lynn Bata, no conflicts, yes.
Thank you. Dr. Sanchez?
Sanchez, no conflict, yes.
Thank you. Dr. Cotton?
Camille Cotton, no conflicts, yes.
Thank you. And Grace Lee, no conflicts, yes. So the motion passes as written, and I believe it is 13 yeses and 1 no. And with that, I'd like to thank our committee members for your time and for this robust discussion. I did want to offer an opportunity if anyone would like to make an additional comment about your vote, if you would like to raise your hand. Dr. Talbot.
So I wanted to be said, I am just fine with kids getting a booster. And this is not me against all boosters. I just really want the U.S. to move forward with vaccinating all kids so that all kids can go back to a normal life. And I don't think it's fair for the 12 to 17-year-olds who have been vaccinated to risk myocarditis again for an unknown benefit because their colleagues won't get vaccinated. And so I think it's incredibly important that we continue to follow the safety of these vaccines, the immediate risk of the myocarditis after the third vaccine, and the incremental benefit of a third vaccine in these kids. If you are a parent out there who has not yet vaccinated your child because you have questions, please, please talk to a healthcare provider and do not use social media. It is so easy to take things out of context and to try to get new Twitter followers, and none of that is going to help you protect your child. Please talk to their pediatrician. Please talk to a healthcare provider. and let us know what questions you have that we can answer. Thank you.
Thank you. Dr. Cotton.
I'm glad to see that we voted in favor of this. I would like to suggest that at upcoming ACIP meetings that we strongly consider advancing the time frame for booster doses for immunocompromised patients. I just heard that at my own hospital, of all transplant patients, kidney transplant patients with COVID-19, 25% have happened in the past 2 weeks. We are in a state of crisis. This is an emergency. We really need to act soon. We can't wait. This is a matter of major emergency and crisis. Thank you.
Thank you, Dr. Cotton. Dr. Long.
Yes, I just want to say I'm not thinking of children taking the risk of a booster dose to protect themselves because others haven't taken the risk of their primary dose. First of all, we didn't talk about it very much, but I have very low concern for myocarditis vaccine-related after booster dose. It's far enough out. The antibody levels are not that super spike that occurs a month out. And I think the data have shown that it's much lower risk after a booster dose. So I didn't consider in my deliberation that there were any trade-offs here of anybody being a soldier when others weren't, but rather the potential benefit for the children, especially in maintaining the life that they should be able to have, that booster doses in the short run might affect. Thanks.
Thank you. Ms. McNally.
I really want to thank the CDC for all the work that went into today's meeting and to my colleagues for a very robust discussion. I have 2 children in this age group who I will be taking to get boosted, and I really want to encourage all parents with questions to get answers to their specific questions about this vaccine because it is so important. Thank you.
Thank you. I do not see any additional hands raised. With that, I think what I'd like to do is ask Dr. Wharton if there's any additional business or if anyone has any objections to adjourning today's meeting.
No, we can close.
Oh, Dr. Lee, this is Patsy again. Is someone able to answer my question about the younger age group timeline?
Oh, thank you, Ms. Finchfield. I don't know if we have a colleague from FDA who might be able to comment. Dr. Fink, are you still on?
Yeah, I'm here.
Thank you.
Clearly, the reported increases in pediatric hospitalizations overall, including children under the age of 5, are concerning. As we all heard from the press release issued by Pfizer, they have an ongoing study of primary series vaccination in children 6 months to 5 years of age, and they did not meet the immunobridging success criteria in one of their analyses. And so we are evaluating what options are possible for moving forward with evaluating the vaccine in this age group in order to figure out how to best make available a safe and effective vaccine as quickly as possible. And I don't know if anyone from Pfizer wants to comment either.
Yeah, this is Alejandra Goodman, just checking that you can hear me.
Can.
Okay. Hi, everybody. I am in the Vaccine Clinical Research and Development Group at Pfizer, and I will give you a little bit of a high timeline, but I would like to start by stating that, in view of all the discussions that we had today and the disproportionate burden of disease and hospitalization in children, Pfizer has as a big priority to develop to come up with the vaccine and the right number of doses that is safe and effective. And as Dr. Singh just mentioned, we did not meet the non-inferiority criteria for the 2 to 5-year-old. The non-inferiority criteria was met for the younger age group, which is 6 months to 2 years of age. I do want to say that through a meeting in late December with the DMC, the vaccine is safe. And so this is an immunological criteria that has not met. In view of that and all the information that you discussed today and the data that is becoming available about the effectiveness of 3 doses of the vaccine for those who are 16 and older, and as of today, those who are going to be vaccinated who are 12 and older, and the laboratory data that we have also for the Delta and other variants, it is becoming very clear that this might be a 3-dose vaccine. And so the study is being amended to give a 3rd dose to everybody who's less than 5, at least 8 weeks after the last vaccination. And we're also going to be providing a 3rd dose to those who are 5 to 12, at least 6 months after the last vaccination. And at the present time, we are looking to have the data for the less than 5, the 3-dose data, the immunogenicity data by either end of March, beginning of April. So late Q1 of this year, so a few months from now.
Thank you very much, Dr. Gortman. And with that, I'd like to close the meeting and again express our sincere gratitude to the ACIP members, ex officio members, liaisons, CDC staff, and other federal collaborators for your time, your knowledge, and your commitment to the process and your willingness to have a challenging and respectful discussion today. And with that, I will say the ACIP meeting is now adjourned. Thank you, everyone, and I'm sure we'll be talking again soon. Take care.